appreciated that wonderful introduction. It is such a pleasure to be here with all of you this afternoon. And I want to first thank Sparks and its staff and leadership team for this wonderful opportunity that brought us all together today. It's really Sparks' dedication to cultivating and building meaningful relationships and engaging with the autism spectrum disorder communities of color in their work and research initiative that made it all possible for us to convey here today. So thank you. This is truly evidence that no matter how big of a powerhouse you are, you still need others to help inform what you do. So I want to open up my discussion today with a reflection. I want you to join me in reflecting about what meaningful partnership and collaborative dialogue actually means. And you can go to the next slide, Dominique. So I want to take me back to November 20th of 2019. It was a little after 2 o'clock in the afternoon when I found myself for the first time walking down the halls of the main entrance of the World Bank with a few colleagues of mine from AUCD Network, following a brown bag meeting that we had in Washington at the World Bank. And the meeting was on inclusive education in Africa with the World Bank staff. Suddenly, as I walked down this hall, my eye caught sight of a bronze sculpture that took me back to my childhood years in a small remote village in West Africa. With all kinds of emotions running through my head, I turned to one of my colleagues, Karen Heat, remembered and said, Karen, I found myself back home looking at this sculpture. Now, the sculpture is a blind man and a young boy is leading him. This is a very common practice in my home country, right? And although I saw this all the time and in real life growing up, I never thought anything of it. I did not even notice the writing in front of the sculpture until Karen pointed to it and said, look, it reads, sightless among miracles. The thought of why the World Bank will put it there forced me to really do some research and said, okay, I need to look at this more. Sightless among miracles? So this is what I found, that the sculpture is meant to symbolize partnership, collaboration, leadership, and interconnectedness. So the stick being the young boy's means to direct and lead the way for the elder, the old man that he's leading, links the two of them together. At the same time, the boy knows that one day he might be at the other end of the stick and their fate are interconnected, and that partnership is thus necessary. So as you can see, we do need each other. We need our autism community in all that we do. We need people, Black people of African descent, in all of our advocacy dialogues. So when we think about meaningful partnership and broadening of this footprint in the Black community, we need to remember that it goes beyond Black History Month activities. And I really want all of us to think about Black history knowledge, right? Replace that and put Black history knowledge. As one scholar puts it, a people without knowledge of their past history, their origin and culture is like a tree without roots. So it is our duty to learn and respect the Afrocentric worldview and the view, looking at it as a protective factor. When we say Afrocentric worldview, we want to be able to look at the sets of beliefs and values and assumptions that reflect basic African values in all that we do. Those are the values that are found among persons of African descent. In learning about the Afrocentric worldview, we are better able to help our Black children, youths, and family attain a critical understanding of themselves and their identity. Now, as you think and look about today's webinar, that is on disability, mental health, faith, and Black people of African descent. And Sparks is bringing us together, giving what they have to offer with regards to research and helping us to really come together and have a dialogue. Again, meaningful collaboration, keep that in mind as we journey through this webinar. Culture plays a big role, and culture does represent the vast array of behaviors, the ideas, the values, the habits, and the practices that provide all of us with patterns of interpreting our reality and the ways of lives. This is really why it is very important that prevention efforts, research, intervention efforts for our Black children and youth and family should always focus on the restoration of cultural values. We need to join efforts in increasing our Black families' resilience by strengthening their cultural pride and identity. Black history knowledge is critical. And by fostering cultural values, we are better able to encourage and support even their spiritual sense of self when we pull the faith, spirituality, and religion into the mix. We have this belief in the force greater than oneself. So, and I encourage and I support all of us in our work as we embrace the collective sense of self that really resides in our Black community. The I am because we are. We should not shy away from teaching about the equal values of the past, the present, and the future of Black people. We can better reach this goal by engaging in collaborative dialogue and countering as well as deconstructing the oppressive systems that prevents full participation of Black families and children in our research initiative and in our training and treatment and intervention programs. Collaborative dialogue is what helps us engage in joint problem solving and knowledge building. We need from each other. We need to learn from each other. And in doing so, we are better able to gain new insight and better understanding of what is in front of us. When we engage people in a collaborative dialogue that is meaningful and allow them access to relevant information about the topic that is being discussed, the result is active engagement. And the feeling of this mutual respect and love is what results. Our community strength depends on us addressing the systemic inequities in our Black communities and the struggles that the Black communities face. We cannot stop from engaging in honest dialogue about the inequities that exist among racial, ethnic groups in ways that we can effectively cope with racial barriers and biases. Nor can we cease from engaging in teaching that emphasizes the harmony and equity in care and positive relationship that can exist when we all come together as a group. I was asked today to discuss what we know about mental health, mental illness, and disability in our Black communities, and also to talk about some strategies for addressing barriers of disability diagnosis and treatment service access, as well as touch on the mistrust of medical research that was created by the historical event and the role of our faith communities in addressing these challenges. Now, that's a lot to cover in depth in less than 1 hour. I encourage you to please know that this conversation is going to continue beyond this webinar. And I said disclaimer, I wanted to make sure that please note that the information I'm presenting here today may not necessarily represent the entire Black community and belief systems of the cultural groups for which examples are given. Next slide. So what do we know about mental illness, autism, in our Black communities? So let's start with mental illness in our Black community. We all know that mental health is an important part of our overall being and well-being, both emotional, psychological, and social well-being. And it does affect what we think, how we feel, and how we act. So mental health is important at every stage of life, from childhood through adulthood, and it helps determine how we handle stress related to others and how we make healthy choices. So what it means to be a Black person in America belonging to a certain race can no longer be taken for granted. So we know research tells us that racial discrimination does impact a large number of Black youths, children, and families. About 97% of Black youth report experiencing at least one incident of discriminatory treatment in a 2-week period. And Black youths begin to understand the negative racial stereotypes and effects of discrimination before 10 years of age. After 9 years of age, Black boys are perceived as less innocent than older, and also they're looked at as if they're older than white boys. And they are also prematurely held accountable for action during a developmental period in which we know their peers are afforded the presumptions of innocence. So this age group is particularly susceptible to the effects of racial oppression and related deleterious mental health consequences. Serious mental health rose among all ages of Black children and Black people. We think between 2008 and 2018, and in Black youth ages 12 to 17, major depressive episode increases from 9% to 10.3 between 2015 and 2018. It's even higher now. So mental health is a key developmental factor, and we should not stay away from really paying close attention to it. Autism diagnosis in our Black children, as we look at it, when we look at it, according to CDC, 1 in 54 children in the US have autism. And among them, Black children are less likely to be identified with ASD, autism spectrum disorder, than white children. Despite that, the risk of developing autism spectrum disorder are the same across racial ethnic backgrounds. It's no difference. So with regards to referral, Black children have more difficulty getting a referral to a specialist. Even when Black parents rate their children's symptoms as severe and needing expert care, they still have the most difficulty getting a referral to a specialist. And now you talk about under-identified and misdiagnosed and underserved. Several studies have also found that Black children were less likely than white children to receive mental health treatment and more likely to be misdiagnosed or receive the diagnosis of ADHD, attention deficit hyperactivity disorder, before receiving an autism diagnosis. So there's a clear racial disparity in autism diagnosis that has nothing to do with the socioeconomic status. But then you think about the role of culture and religion in all of this, in the diagnosis and treatment of autism, right? Some of our parents may not necessarily recognize the early signs and symptoms of autism. We know that poor knowledge about autism symptoms and child development may influence early diagnosis. We also know that the expectation of children's behavior and development do vary across culture. So culture does play a role in healthcare. Some of our families may prefer to discuss their concerns within their own families, or even to take it to their faith leaders and their faith community before they bring it to a clinical setting. Autism diagnosis can be also perceived as shameful in our communities. Black parents and families may hide their children's diagnosis and sometimes are pressured by their families to conceal their child's atypical behavior. And some may even recommend to the parents to just wait and see, or to use a firm discipline to correct unwanted behavior. Now, on the other hand, culture does serve to protect and buffer our Black parents and families from the stressors associated with having a child with autism or other developmental or intellectual disabilities. For our Black people, family is the context in which we live and breathe. And so each member of our Black family exists within our family system. Now, this is a good reminder that the role of ethnic enclaves, or what I call the group identity, our groupness, plays a very important role and should be respected and celebrated in all that we do. It is also very important to understand the role of spirituality and religion in understanding disability in the Black culture. Our belief systems helps us to live our life and to positively reframe difficult situations and to cope with life challenges. Some of our Black parents have reported placing their trust in God to lead the way as they seek and receive services in our complicated and confusing healthcare systems. They pray before they make a call for a referral. They pray before they show up to their first appointment, allowing God to lead the way, allowing God to touch the hearts of those who are going to be meeting and working with their child. Because of their faith, some parents see their children with autism as a blessing. Now, the autism-related stigma is a real thing, right? The cultural insensitive service delivery is also there. So being Black and having a child with autism is considered really double disadvantage or double stigma. Our Black parents fear that their children will be shunned by peers and others, including those who work with them, and they will be judged, and their parenting skills can be questioned if their child is diagnosed with autism. So the fear is real. Some parents even get blamed for their child autism diagnosis, which leads to more community isolation and shame, and the stigma and the shame delay evaluation and treatment seeking. It also decreases participation in autism research, which is highly needed. We need to get involved and be a part of that. On the other hand, when parents actively advocate for services, for example, health or educational services, or even question the validity of recommended intervention, they are sometimes seen as being aggressive, unprofessional, or unworthy of service. So this ongoing social discrimination can lead to feelings of disempowerment and affect parenting and even help-seeking behavior. And we know that early referral to a specialist is what helps with early diagnosis of autism, and early intervention does optimize developmental outcomes. So yet, our Black children are not being referred to specialists for diagnosis in a timely fashion. So given the misdiagnosis and late diagnosis of autism disorder in Black children, we need to join efforts to increase our Black parents and community members' knowledge and awareness of autism and available resources so they can better support our children's needs. So I invite all of you to join the call to target strategies that increases awareness of autism among Black families and to break down the barriers that prevent our families from being referred, from being evaluated, and from being diagnosed at early age. So now that I've actually talked about some of this, I want us to be able to, I'm going to touch a little bit on some of the barriers, and then we're going to discuss some of the strategies on how to address those. You can go to the next slide. So let me just quickly highlight some of the common barriers to diagnosis and treatment access. And before we talk about ways to tackle those. So historical trauma, right? And adversities, right? Which includes race-based exclusion from health, educational, social, and economic resources, thus translate into socioeconomic disparities that are experienced by Black people of African descent today. Socioeconomic status, in turn, is linked to mental health, right? Many historical factors and current events that we see in our today's world shape the functioning and structures of our community. Historical and contemporary negative treatment have led to mistrust of authorities, many of whom are now seen as having the best interests of Black people in mind. And you bring racism into the mix. It's another aspect of this historical legacy of Black people. The negative stereotypes the rejecting of attitude continue to exist with adverse consequences for mental health of Black people. One of my colleagues, Jones, highlighted 3 forms of racial racism in her research. That included that we should really pay attention to individual racism, the cultural racism, and the institutional racism. Now, as you think about individual racism, this is really this belief that another racial group is inferior, and the interpersonal behavioral enactment that maintain these beliefs is the example, person against a person, right? The cultural racism is this worldview that reflects in beliefs in racial differences that favors one group cultural heritage over another. And then we talk about the institutional racism, which is this manipulation of societal institutions in ways that limit access and rights of a group. So we have all the discriminatory laws and social policies. And I said that God created human race, but we humans, we created the racism, right? We also created structural racism, which is really the system in which these public policies and our institutional practices and our cultural representations and other norms work in concert to reinforce and perpetuate discrimination, oppressive action, and racial group inequities. We need to shift the structural power. The structural power is what is embedded in the social and organizational context, such as our school systems, our legal and political systems, our social service systems, our care institutions, just to name a few. It includes laws and policies that have historically denied Black people and other marginalized groups of their rights. When those being oppressed try to oppose or compete against those structural dominations, they face disciplinary power, a strategic technique by the dominant to continue to oppress the marginalized. Stigma leads to stereotype, right? And stigma can also lead to denial of opportunity and equal rights. There's also the stigma of mental health and stigma of disability. The stigma of poverty can induce self-blame and self-hatred in ourselves. Stigma associated with disability and seeking help is also real. It is estimated that among children and families experiencing poverty who are in need of mental health or other services, less than 15% receive services and even fewer actually complete treatment. Despite all of these injustices and inequities, we know that theories and research suggest that Black youth indeed does demonstrate self-determination and resilience in the face of all these adversities, when we provide them with the tools to challenge racially oppressive notions. Cultural-based attitude about mental health and fear of being labeled crazy and losing your child to social services is a real thing too. Confidentiality concerns is in the mix, and fear that friends or neighbors will disapprove if you seek care. So internalized racism is what leads to feeling of this unworthiness of treatment or belief, or I got this, I can handle it. Lack of concerns by those who you are seeking help from, what we call the empathy gap in the care of Black people. For example, the inequity treatment of pains in people of African descent. Distrust of our medical care system is huge, and possibly the consequences of seeking care because of dislike of treatment options and recommendation by culturally insensitive service providers. That leads to a strained parent-professional relationship, and partnership with providers are always in the best terms. So when we have this lack of cultural insensitivity in our health and research systems, it does impact everything. It impacts even the economic and financial things that we need to continue to move our programs forward. So we need to address these barriers. Not doing so will be doing a disservice to those that we serve. Simple things we can do, simple things as even differences in the cultural meaning of same symptoms, behavior, even extending our wait list and making sure that we're able to really accommodate parents or families who may have competing demands, opening our insurance system so that medical assistance insurance is honored and respected and can get you into treatment and get you early diagnosis as quickly as possible and early evaluation. Scheduling conflict is a real thing. Service location, our families living in scarce resource areas. Many of our families live in communities where treatment services are not easily accessible. Helping families manage in communities of scarce resources can affect access to needed services and timely access to needed services. So we can sit here and talk about all of these barriers, and the list can go on and on. So let's kind of go to the next slide. Let's talk a little bit of what we can do to begin to really take a closer look and address these. You can go to the next slide. So looking at Healthy People 2020 as to what defines health, individuals with disabilities, their abilities, and their health outcome more often depends on the community. So I invite you to look at our community as a host. This is a framework that will help us shift this mentality of thinking that we are the one who needs to really invite our community into our spaces. Our community are the one who is inviting you into our spaces. Okay, this means that we should not underestimate the power of community. Community is what makes us stronger. In the Black community, that's what we have. So let's strive to always create opportunity that allow for meaningful collaboration and partnership with all. Think about the organization that you're a part of. If you're a researcher, a practitioner, how are you entering any of these organizations? How are you entering your community? Should you consider yourself as a guest into the community? It is the community that should invite us into their world. Before you enter, community is the host who sets the table and invites you and I to have a seat at their table. We don't force ourselves in, and we don't claim that we are the one to give our community a seat at the table, when they are in fact the table, and we are the outsider and they are the insider. And from a human rights perspective, people with autism, intellectual and other developmental disabilities have the right to fully participate in the general community. And they participate less, regardless of, we know that this full participation is what we are all called to do. Community is also a region that knows no nationality, right? Race, ethnicity, religious affiliation, socioeconomic status, gender, age, level of education, we're all in there. If we are to address the structural injustices and deprivation of civil rights and the personal experience of exclusion and shame that individuals with mental illness, with autism and other disability experience, we need to come together and work together and include all voices, including the faith community voices in all advocacy efforts. We all need to engage in ongoing collaborative dialogue that translate into real world solutions and that helps us solve real world problems. We need each other to engage in ongoing, again, really natural dialogue, okay? This is the only thing that draws us to each other, and we can tap into each other's strengths to make our world a better place. People with autism and other disabilities and mental illnesses have many strengths and can play a valuable role in our communities if they are provided with the opportunity. We cannot agree that a diagnosis does not define a person, and it does not define their talents or their ability to serve as an active member of our community or as an active member of our research team. The consequences of denying someone equal opportunity to actively engage in their own treatment goal decision-making in disability research and other community activity can lead to greater distress. And when we think about the four well-beings of life, again, you think about the social, the economic, the environmental well-beings. which then leads to a greater distress in their mental and spiritual well-being. What are we all called to do? We are all called to know God. We're bringing faith in. But more importantly, we are called to experience God. But behavior that many people with disability and autism develop to cope with the environmental sensory and to experience life and God are often socially stigmatized in our community. Why is that? That's a question that all of us should be asking ourselves. Knowing God implies use of cognitive processing, right? A learning process that may be difficult for an individual with autism. On the other hand, experiencing God offers us the opportunity to experience the divine that resides within us. When we think about experiential learning, we all can agree that learning through bodily sensation and emotion may work better for individuals with autism and other disabilities. Right? If we acknowledge the important need to experience God in our faith community in our life, then there is no need to prevent children with autism and other disabilities from participating in their faith community activities. So we should be creating spaces and making accommodations to be able to nurture that experience. You can go to the next slide. So what is meaningful partnership? This is a pathway, and I look at this as really an arm that includes the knowledge generation, the mobilization, the adaptation, the application, and the integration, all as a whole. You draw from the power, the knowledge, and the relationship. Meaningful participation is really something that we all need in all spaces. Effective outreach and collaborative engagement and relationship directly affect health outcomes. As providers, as researchers, we need to engage in efforts that brings in our individuals with autism and their families and other disabilities in all research and health activities. This is critical to promoting health. Now, how do you connect, engage, and sustain those relationships, right? Remember that relationship is a two-way street. So this implies to individuals with disabilities, parents, families, and provider. How do we do this? First, it's really important that we know how to reach out. We reach out and to make positive connections with Black families with autism, with disabilities, and their families. When we provide opportunity that support full engagement and meaningful collaboration, everyone feels welcome and include all result in lasting relationship and positive health outcome. Now, we can do this if we're not constantly thinking about how do we foster meaningful partnership. We must engage in shared leadership, or we talk about shared decision-making in all interaction. And the goal that we are trying to really put in place should also include the voices of those with autism, families, Black families, and their children. It is also important to support Black families' autonomy and to communicate with their entire support system, the positive players that I call it. And that also includes our faith leaders in our faith community. Those are the positive players that play a big role in how we navigate our life challenges. It is important for us providers and researchers to also enter the Black communities with respect. Respecting a community culture and space is a good practice and is a best practice. Okay, engaging in effective collaboration and meaningful participation is what helps us to sustain relationship. We cannot sustain relationship without those. And for us to be able to make referral to services and sharing resources becomes much easier when we have meaningful partnership established. In a recent article that I wrote, I had noted that if we are to begin to engage with our communities in a more intentional and meaningful ways, we have to do so by including all voices. Okay, we must ask and respect the personal and structural level questions that include, but not limited, how am I planning? How am I entering into this community of people? Am I comfortable working with them? Am I including them in their research, in my research question as I move? Am I collaborating with the community stakeholders and incorporating their input at all phases, not just one time sit on my table and help me brainstorm idea and then bye, don't come back. No, we have to include them in all phases of our program planning, our program implementation and evaluation. We also need to ask ourselves, am I promoting and supporting and sustaining shared goals and decision-making dialogues at all levels, local, state, and national, including international levels? Okay, am I creating meaningful partnership and making time, resources available, including technical assistance to parents and families and community stakeholders in my organization so that they can effectively engage and sustain research efforts and intervention efforts and sustain those meaningful partnership that has been established. So we create something, we want to maintain it. Next slide. I won't spend too much time on this quick diagram, but this is really an inclusive practice framework that was recently created by myself and one of my training students. So we kind of looked at to try to come up with ways that we can better begin to really, especially the faith community, look at their spaces. So when we try to embrace inclusive practice, it's really looking at a pathway in which the barriers and the facilitator can create both positive and negative consequences, which can hinder or facilitate inclusive practice in our spaces, whether it's organization or whether it's in your faith community. Each of the level we identify in the inclusive practice framework, individual level, faith, community level, and system level does overlap and must be considered together when you are assessing any intervention in your spaces. The inclusive practice barrier and facilitator does describe key findings in the literature that factors that can hinder or facilitate inclusive practice. And that does include attitude, our individual attitude, organizational attitude, the education, and the accommodation being the most common themes that we found in the literature. But you want to start with you, self-reflection. Who am I? Because we are the one who makes the community, right? An organization doesn't just exist, it exists because people are the ones that are within those organizations. And if everyone can actually get the attitude check up done, it helps to begin to bring to light what is hindering us from really creating and including inclusive spaces for our families. Next slide. So how do we address some of these barriers through a culturally sensitive lens? Forming collaborative partnership is a critical component of optimal service delivery. In the multicultural healthcare system and research settings that we have, it starts with cultural knowledge, right? I did mention Black history knowledge. Now I'm bringing you and reminding you again that it really does start with cultural knowledge. Remember that knowledge is shaped by individual, family, community, histories, okay, cultural and spiritual beliefs, and other social experiences. If you have ever struggled with addressing or meeting the needs of a Black person with autism or family, it may mean that you're not partnering with them through a cultural lens. We know that the meaning of health does vary across culture, right? In African culture, health is more than the absence of disease or symptoms. Health is viewed as a balanced relationship between people, nature, and the supernatural. And that includes a relationship with God, right? It is important to know that a person's understanding of health and illness and how they deal with it can be influenced by their culture. We may know that, but in practice, we don't always remember to acknowledge that and respect that. It is only when we are able to recognize and accept that behavior and beliefs are truly influenced by culture, language, and social interaction and relationship. Only then can we better design and deliver services that can better lead to effective care outcomes for our Black families and children that we work with. Partnerships are built on a foundation of pre-existing and trusting relationship, right? One cannot be culturally sensitive without being culturally responsive. So providing cultural responsive care, the provision of this health in clinical care settings that incorporate understanding of and respecting of another culture is critical. And this means really setting up these behaviors and attitude and policy that come together in a person, that comes together to form a system, that comes together to create our agencies where we work. There all needs to be in a cross-cultural effective responsiveness. Let's not try to be culturally blind, which is when one believes that we are all the same and that a person of color or a Black person is just like everyone else, right? A culturally blind person does not truly see a Black or Mexican or indigenous person for who they truly are. They are discounting all the wonderful cultural attributes they provide to our society if they do so. The process of building cultural proficiency among individuals and within teams really means that you have to bring your social, clinical, and behavioral components together. Researchers and our care providers should recognize their own identity, its relationship with power and oppression as well, and how those understanding, they can use it to foster equity and respect for the diverse families and community that they serve. You can go to the next slide. So I want to spend a little time and talk about cultural responsive research, because this is put together by Sparks, right? And when we think about ethical research, what is that? It really means not putting people at risk of harm, right? For the good of others, making the intervention being tested available to the people and community who participated in research. Are we doing so? If not, we should be doing so. Allowing people the right to withdraw from research if they need to do so. Not exploiting our vulnerable population for the benefit of others, and not exploiting low-income communities for the benefit of us, okay? Unexploitative research is an unethical research. There's no two way about it, right? Researchers must avoid the exploitation of Black people who agree to participate in research. If we're trying to rebuild the trust in our research settings and in our medical setting, and we need to ensure that they are not just merely being used for the benefit of others. Our research participants should be treated with respect and valued as a partner, true partner, who also contributes to the common goal. We talk about respect for human subjects in research and don't always practice what we preach, right? We take the IRB test and get the certificates hanged up that we've completed it, but we need to actually put those in practice. We must ensure that all voices are included by ensuring fair selection or participation in research, right? Avoid offshoring of research that puts people in less developed spaces at risk of harm. It means really not using or diverting our local resources to the benefit of a research team and therefore putting unnecessary burden on the people and the Black community. That leads us to equitable research, okay? And you must remember the difference between the equality and the equity. You know, equality is really treating everyone the same, but equity is really giving everyone what they need to be successful, including all people, all voices at all stages of our research process and beyond is research equity, right? All must mean all. And equitable research does create opportunity for all of us, right? To participate and in our own abilities. And it does respect multiple identities and multiple abilities, right? Research communities should always prioritize addressing the accommodation and accessibility needs of each individual and what they bring and what they can offer. We need to address the health inequities and mistrust within our Black community, right? That's a big one. Doing so requires an approach that considers both prevention alongside improving access to quality care and educational services for our Black children, especially those with autism and other developmental disabilities. Co-production helps, right? And a meaningful partnership helps to increase trust in the area of research and treatment. Us researchers and health professionals should partner and work alongside our Black families and community to co-produce interventions and services that are acceptable and that are equitable. Doing so will also help us with help-seeking behavior, and acceptance of the intervention recommendation will improve as a result. Meaningful and intentional outreach to members of our Black community can open up channels of communication and improve mental health awareness and reduce stigmas related to help seeking and the barriers related to really accepting autism diagnosis. So let's try to embrace the cultural responsiveness and sensitivity, adopting a cultural humility as we go into our family spaces and work with them. Okay. And I can see I got a boss here to kind of keep an eye on the time here. All right, so you can go to the next slide. So the role of our faith community in promoting health, we know the huge role our faith communities play and how important it is for us to really try to work with them as we attempt to understand and organize our communities. It's a national survey that found that 50% of Americans with disability attend church or a synagogue or any other place of worship, compared to 57% of those without disabilities. So faith was considered important by a majority of people with or without disabilities. Like others, people with autism and with any form of disability want to participate in their faith communities. We are not only social and cultural being, we are also spiritual being. And spirituality does represent this deepest form of connectedness. And so one's well-being comes from being connected and engaged and giving one's life a meaning and value. And we know that lack of life meaning does lead to distress, and it does lead to problems, right? So when we look at studies that actually tells us that the strong association between spirituality and religion practices and happiness, people who are more committed to their religious practices and to their faith communities and have their spiritual belief are happier, healthier, and have more coping resources than those whom religion and spirituality are less important to. So our faith leaders can be very effective in modeling appropriate behaviors and communication to their members, addressing the stigma and denouncing the discrimination against individuals with autism or mental illness. Our faith community leaders are the ones who are consulted for divination about causes of disabilities and diagnosis of mental illness. So they are there. And when we're describing whether a person's illness is God's will or if it's a result of a supernatural power, and if professional treatment is needed, the faith leaders and our faith communities are the first go-to. So our faith leaders are socio-cultural mediators, and they play a role in understanding of the social and cultural aspects of individual behavior and psychological symptoms. So we need to include them in the decision, in the initiative, and in the advocacy efforts that we put forward. Our families also need to play a role in educating our faith communities as well. And I want to touch on that because I think that's one of the questions that came up. So how do we do that? Okay. As parents, as caregivers, as individuals with disabilities, you can help our faith leaders better support our individuals with autism, our children with autism in their faith spaces. So remember the important role that you play in teaching those in your faith community about compassion, right? About understanding of individual differences and challenges and helping them address their fear of the unknown. Parents, you are in the best position to teach your faith leaders and faith community how they can better get to know your child. not just knowing your child's needs, but they need to know your child's unique gifts, the gift that they bring into the faith community, their talents and their strengths. They don't only need to know how to address their needs, they need to draw from their assets as well. You're in a position to suggest strategies that can help address the sensory needs of your child with autism. For example, you can point out the flickering light that needs to be replaced ASAP, or put a cover on it to soften the lighting of the room. You can suggest strategies that will help improve communication. It is important that people speak to you and to your child directly versus speaking to the caregiver. Even when your child with autism is nonverbal, they can still understand what you are saying to them. So help your faith community, help your faith leader understand that. Suggest strategies on how best to work on transition and avoid overstimulation. You go to treatment, you go to therapy, you have all these tools, translate that, help them listen to you, demand that they listen to you, demand that you're at the table and they need to come and sit and listen to what you bring to share with them. Encourage your faith leader to collaborate with your child treatment team, as well as to help them include and develop inclusive spaces in their communities. Our providers have the skills and the tools that they can use to help faith spaces and faith leaders know how to better navigate and how to better support your child in those spaces. That helps also to nurture their growth. When we think about gradual exposure, that can help with really getting into a new environment. Don't shy away from embracing your faith community. Demand a time to meet with your faith leader when there is no too much stuff going on, and bring your child and help educate their staff. When you gradually establish that and bring your child in, turn the temperature down, the child will easily adapt and adjust to their new environment. Everybody learns and everybody's happy at the end. So I want to really encourage you to participate in inclusive practice trainings at your faith community spaces and at different organizations and programs as well, and serve as a presenter or co-presenter when those trainings are being formulated or being presented. You have the expertise to do so and should be at that table and be the one inviting us to have a seat, inviting the researchers and the practitioners to have a seat around you. You hold the power to making a difference in your faith community, in our Black community, in the lives of our Black children. I am going to pause and turn it back to Jabril and see if there's any other question other than the one that I just covered.
Hello, Dr. Ofonedu. That was an awesome discussion. Thank you so much. I think I'm leaving with more tools than I came with, and I hope our audience is as well. We do have time for one question, although I just want to say that this recording will be on Spark, and we'd love to interact with you to answer any more questions that you have on our platforms, but we do have time for only one question. And that is, in the spirit of bottom-up engagement, are there resources a community mental health clinician, non-academic, non-specialist, that does not have advanced level training, i.e. MPH, can use as a guide to help them get started in making effective and lasting stakeholder partnerships, with the idea that this partnership would ultimately help reduce the barriers to care for the families we are working with?
There are, yes, lots of resources, and I hope that you're going to be sharing the slides that I provided. There's a lot of links and resources there, and actually my department email as well as my personal email is also included. Plenty of resources. And yes, you don't have to have a degree hanging on your wall to be able to fold your sleeve and be a part of this effort. You are actually the one that have all the expertise, because you're thinking, okay, upstream level, yes, what can we do? And you need to be the one speaking, giving voice to the problem, because you're on the ground working with our families and establishing relationship and the partnership. And I love that you say, how do we create this lasting stakeholder partnership, demanding that your organization that you're a part of provide the support. What we call organizational support needs to be in place, but you have to give voice. There's a need to give you that support so that you can maintain those lasting relationships. When you get invited, even if you have no time to attend, bring attention to the need that you need to sit at that table and have a time created and covered so that you can participate in those meetings. Entering those rooms where we are lacking voices, you should be the one bringing those voices in and being a part of that. Yes, thank you for that question. Hopefully, when we share all of these resources, that can also help you in your advocacy effort to increasing access to meaningful partnership.